Thank you. Good afternoon. We have saved the biggest, the best for last, we think. I'm Gloria Krahn, Oregon State University, and it's really a pleasure to introduce the panelists today. Some of this work started more than a decade ago when a couple of our profound leaders in the field noted that health is the last frontier for people with intellectual and developmental disabilities. You heard in the last panel. We've got good information, good data on residents. We've got good information and data on state systems. We've got pretty good information on employment, but health has really been lacking for people with intellectual and developmental disabilities. So there have been some cross-agency collaborations going on for some period of time. And much of that has been public-private partnerships, universities, disability organizations, and public agencies coming together. Where we are at this point is a very exciting turn and development that has really grown organically across HHS agencies, and I really credit our agency leaders for doing that. So what you're going to hear today is really a sneak preview on some emerging work that's happening now to improve the prevalence and health surveillance for people with intellectual and developmental disabilities. Our panelists today, taking a line from Andrew Houghtonville this morning, are all really great, important people. So let me just introduce them by name. And because we have 6 people, we're going to move through this really pretty rapidly. And I'm going to step off, and Kimberly Phillips, as our last presenter, will handle the questions for us. So first is Jennifer Johnson, who's with the Administration for Community Living and the AIDD efforts to improve IDD data collection. Second is Julie Weeks, who you already heard from earlier today, and she'll be speaking more specifically from the National Center for Health Statistics perspective on working to develop questions. Our third panelist is Violet Wu, who is representing Department of Health and Human Services Office of Minority Health to give us a quick snapshot. Our fourth panelist is Elsa Haile, who is with the Centers for Medicare and Medicaid Office of Minority Health, who will be presenting some brand new data that we're all very excited about. Our fifth panelist is Helen Lamont from the Office of the Assistant Secretary for Planning and Evaluation in DHHS, and talking about some new exploration around new methods for collecting data. And then our final panelist, Kimberly and I are the bookends from academic entities. We'll be talking about another new way of looking at data, health surveillance through all payer claims data. So without any further introduction or taking any more time, I'm going to turn it over to Jennifer.
Thank you, Gloria, for that introduction. And I'm glad to be here with you all, and thank the folks at UNH for inviting us to be here this afternoon and provide you with an update. Last year, I spoke a little bit about our efforts to update prevalence rates for the IDD population and also to establish health surveillance methodologies for this population. So I wanted to provide you some updates on where we are with this work and give you status of work to come as well. Just to provide some background, in case you weren't here last year or need a refresher, we were prompted several years ago to initiate this effort to, again, update prevalence rates for the IDD population and also to establish the health surveillance methodologies for a number of factors, some of which are probably pretty obvious to many of you here. Primarily, it was that the federal government and state governments are making decisions about policy and program and fiscal and budget investments for the IDD population without a lot of good information on this population. We have, in terms of prevalence, we have data that is, the most commonly used prevalence rates for this population is based on data that was collected in the mid-90s. And we know that A lot has changed since then, and as Sherry mentioned in her last session, there's also a guess that was an underestimate of the actual prevalence rates. So there's a real need to update that information, but also, as Gloria said, health is the last frontier. We really don't understand a whole lot about the health needs of the IDD population. For my agency, you just heard about our 3 projects that we invest in that look at Medicaid expenditures, employment, and where people are living, but again, we're not investing in understanding the health status of this population. So we were really prompted for those reasons to be able to work on this effort. Because really, this is the situation that we're in today. This is, I think it's Dilbert, a cartoon, and it's an exchange with somebody at work who says, what does the data tell us to do? The response is, we only have bad data on this. The next question is, does the bad data suggest what we should do? We should do what we wanted to do anyway. The response is, well, yes. That's called good data. So again, that's sort of the conundrum that we're in right now in terms of the data that we have and the kind of decisions that we're making based on that data. So where we are, or where we have been, I'm going to talk a little bit about where we've been and where we are right now. Once we recognize the need to update the prevalence rates and establish better health surveillance methodologies, we initiated discussions with many of our federal partners who are here today, including staff from the Assistant Secretary for Planning and Evaluation, the National Center for Health Statistics, the National Center for Birth Defects and Developmental Disabilities, as well as some of our own internal experts. We then expanded to talk with experts in the field, both researchers and non-researchers, that really generated a lot of good discussion. And what we were really exploring in those discussions is whether we should pursue adding questions to the National Health Interview Survey, given that it was going through redesign, or should we consider other methodologies to collect this information. So what we ended up doing is convening a summit in November of 2017 so that we could have focused discussions on, again, whether to pursue the National Health Interview Survey as a path for getting this information or other ways to get this information. We had a briefing paper commissioned for this meeting that really gave an overview of why we need this information and what do we know currently from data that's being collected and research that's been done. We had about 40 experts who were invited to join us, again, from different federal agencies, disability organizations, and researchers, and also looked internationally at some work that's being done in Canada. From that, we had 3 recommendations come out of our work group discussions. And one was to, yes, indeed, go ahead and pursue adding questions to the National Health Interview Survey. The other was to look at state administrative data and what could be utilized there for understanding this population. And then again, to continue to consider other strategies and methodologies for collecting this information. From that, we formed 2 work groups. We decided to focus on the first 2 areas, the survey question and the state administrative data. So as I mentioned, we decided to work on the first 2 areas, the survey questions and the state administrative data, and formed 2 work groups that, again, were comprised of the kind of people who attended our summit. We had federal staff and researchers and some other disability organizations that participated in these work groups. With the first work group focusing on collaboration with the National Center for Health Statistics to come up with 1 to 3 questions that could be included on the National Health Interview Survey for a couple of reasons. As you heard earlier, NCHS has been trying to reduce the number of items on that survey, but also it costs $150,000 per question asked, so we didn't have the resources available to really be able to add a whole lot of questions. So that was the charge for the first work group. And then in terms of the second work group, given the work that the National Center on Birth Defects and Developmental Disabilities is doing, which you heard about a little bit this morning, we wanted to make sure we were collaborating with them to look again at administrative data in the states, describe the data that's out there, look at better standardization of that data, and how it could be better utilized, again, to understand this population. We also wanted to look at possible innovations in what states are doing to utilize their existing data and identify any promising practices in the state. These two work groups were tasked with looking at this both within the child population and in the adult population. And where we've ended up is really focusing on the adult population for many of the reasons that Sherry identified in her earlier presentation about what we know about adults versus what we know about children at this point in time. In terms of the first work group and what they came up with in their discussions, we're going to be publishing white papers on each of these work groups, and these recommendations and the discussions will be in these white papers. But what they did is they examined the definitions for intellectual disabilities, and that came from the American Association for Intellectual and Developmental Disabilities. And then they also looked at the definition for developmental disabilities, which came from the Developmental Disabilities Assistance and Bill of Rights Act. Then they worked with the National Center for Health Statistics to determine the domains that already are addressed in the National Health Interview Survey based on those two definitions for ID and DD, and identified areas that were gaps that were not being addressed in the National Health Interview Survey. And what they came up with were items that need to be added related to learning, independent living skills, and age of onset. Also, they're talked about the need to update and benchmark prevalence estimates because the population will be so small that we will probably need to get 3 years worth of data to really establish stable estimates of the population. We entered into agreement with the National Center for Health Statistics last summer to start work on developing the 3 questions in these areas, and we are in the process of working with them in the development of that and the cognitive testing of those questions. In terms of the state and local administrative data work group, they really focused on looking at available data that is currently existing in the states. And again, the examples of best practices that they could look at and identify and share with others. And also looking at the barriers that currently exist and where there are opportunities. And in that, they identified the use of consistent operational definitions and data collection across the states to help with creating better harmonization between different state administrative data sets. And that could be in the areas of race, ethnicity, and primary language where we could have better consistency in operational definitions. There also needs to be opportunities in terms of promoting this kind of research to fill the knowledge gaps that in order to take advantage of the data that is out there, we need to make sure that we're promoting that research to be done. And then also make sure that we're creating opportunities for states and researchers to share the information that they are learning so we can inform the programs, the practices, and the policies. So in terms of where we go and our next steps, we, like I said, are in the process of collaborating with the National Center for Health Statistics to develop the questions for use in the National Health Interview Survey. And the idea is that if we can do that, then we can possibly apply those same kind of questions to things like the US Census Survey and the American Community Survey. So our goal right now is to create those questions, and then hopefully if we are able to get those questions established, place them on the National Health Interview Survey. We also want to do a more comprehensive scan of state data collection efforts. Like I said, in the second work group, they've done a level of that, but we want to do a more comprehensive scan of that. And then to, again, help with that exchange of information and transfer knowledge, to develop learning collaboratives and our community of practices, to help states develop more data harmonization and data linkages between the different data sets and the different data that they are collecting. And again, continue to identify and enhance those data collection methods within states for the IDD population. We identified some promising practices that are going on in particular states around the use of state administrative data, so we want to be able to promote that. And then finally, another area of attention in these work groups is the inclusion of racial, ethnic, and linguistic data in the surveys or the data that's being collected so that we have an understanding of, and again, this kind of came up in the last panel, what we know about this population as it relates to their racial, ethnic, and linguistic skills and competencies. With that, one of the areas that we are looking at too is how we include the territories in the data collection efforts, because not all territories are included in different surveys. So trying to tackle that issue is an area that we're looking at as well. And I believe we're holding questions until later, so I will turn it over to Julie.
Oh, it's on its way.
Okay.
Through the tubes.
Okay. Hello again. Much of my presentation adds a little bit more information to what Jennifer just said. She has queued me up very nicely. It also reflects the work of Work Group 1 and kind of the status where we are at the moment. So the state of IDD statistics, I don't need to go over the top of this slide. We have been talking about this all afternoon, if not longer. People will say, so why don't we? Just add a question. Ask the question, what's the problem? All of the time. And just when you think you've convinced your higher-ups or your peers or the advocacy group or whatever, and they really have it, they say, no, why don't we have the data? Like, why has it been 20 years? Why don't you just ask a question? So I'm actually really hoping to impress upon this audience, and I probably don't have to work too hard at that there are major challenges to asking questions to really accurately identify this population. The fact that there are varying definitions, that there are diagnostic tools for identifying IDD, that there are programmatic definitions for service provision, the fact that there are surveillance approaches to identifying this population make it very difficult. And it's so interesting because even some of our questions in the room today reflect that the people who do surveillance really don't like the diagnostic tools. And the people who employ the diagnostic tools all day long would never, ever use any of the questions that were employed in the HIS. And if you look at what is legislated, well, who can measure self-sufficiency? It can't possibly be, are you just working? We just heard that that is not sufficient, but we do the best we can. And I'm spending a lot of time on this slide because it has these challenges, and I always start out with that definition. This target population is very small. Our major surveys are not designed to well identify small populations. So what you end up having to do is you have to ask those questions over a period of several years, wait for it, and then collapse. And even when you do, if you want to run that data by any two other variables, well, now your cell size is too small anyway. So you've waited for nothing. But the small population is really, really a big issue. The group quarters, I think there should be a whole talk about this. This is evolving in a way that we can't keep a handle on it. We know our population surveys don't go into group homes and other types of institutionalized areas. We also know that this population is morphing and living in places where we can't even put a definition on it. Census can't, we can't. So we're not going to get everybody via these surveys. I probably don't have to spend a lot of time talking about how difficult it is to get accurate information from respondents who have IDD. Not all of them. And the issue of proxy versus self. Which do you prefer? Which gives the most accurate information? This is no different than asking a proxy if, that person, if the respondent is having, mental health issues. Self and proxy is very difficult. There are always language and cultural considerations. The words we use here in Washington when we are talking about this group are not the words that are used elsewhere, and we can't use those words anymore. So this is a real big deal to go into every geography in the 50 states and not use words that they use every day that are still in very common use. And then I kind of want to just touch on the person-specific IDD circumstances. The experience of IDD is eclectic, and there's no one-size-fits-all. And if I'm going to only get to ask you a couple of questions to identify IDD, then it's going to be really hard to do that with some accuracy. So here's an example. We tend to think this has to develop before age 22, for example. Well, if this was not a diving accident or a sudden thing, the memory and how people report this is very different than when there was a clear demarcation of change in health and status. So not an easy thing to do. The challenge, again, is to measure the broad experience of IDD. I put an asterisk on that all the time because every person experiences IDD differently. Using a limited number of questions, in a consistently comparable manner. It's a really tall order. And we, again, as Jennifer mentioned, wanted to target primarily nationally representative surveys, the HIS, but certainly be flexible, put them elsewhere, focus on domains where data were not available, and absolutely take a functional approach to measurement. We do not use the medical model any longer. My next 4 slides I'm going to run through very quickly. Just look for stars and arrows. This just demonstrates how difficult it is to address this definition, this legislative definition. You guys probably, you all know the pieces of it. Defining what we want to find. The work group decided that to focus on these 2 areas, this age item and the results and functional limitations in these kinds of things you see. Economic self-sufficiency, that's always my favorite. So the first thing we had to do was really focus. There's the focus, those 2 things. Then, and here I'm only showing those 2 things, we say what is already on the survey, what's already on the HIS, it's where the stars are. So what's left, what do we have to develop, what's our work plan, it's where these 3 arrows are, and that mirrors what Jennifer just said. We are using a functional approach. It is a 2-pronged approach. You focus on limitations in major domains of functioning. So just like we don't say any longer, do you have a disability? We tend to ask, do you have difficulty in, and we mention major life domains. We certainly don't say, do you have a substantial limitation in self-direction? We think about, well, what does that mean? What are the domains of functioning where a person experiences difficulty? And you craft a question to get at whether that person has difficulty there. Is this the question? Maybe not. But this is taking a lot of time in the work group. A lot of time was taken to get to our definition. Now we're in the process of how can we ask these questions in these areas that we've identified. And lastly, you measure the environmental barriers separately from the limitation. Okay, cognitive testing. I only have a few minutes. I'm not going to really teach everyone about cognitive testing, but I do think that it's important to note that the best question design is not based on expert opinion. We have all, at some point, whether in graduate school or afterwards, sat in a conference room and come up with some survey items and thought, yes, this is going to work perfectly. It's asking exactly what I want it to ask. When we have a battery of questions for IDD, we will be able to demonstrate that they work. That's a fabulous, fabulous accomplishment for ACL and its work group and many of the people sitting here in the audience. And we will know that the question captures what we want it to because we tested it. So the goals of cognitive testing really is this construct validity issue. You know, we ask these respondents who come in, you know, and what we're looking for is how do they understand the survey questions? Do they understand them differently? Is there something about their circumstance that makes them understand it differently, or is the concept so wobbly that people, you know, are just, it's washing over them very differently? You know, does language matter? Does geography matter? What are the socioeconomic or personal experiences that are going to create bias in our data that we didn't intend to have at all? So, you know, here's the question response process. You take these respondents through the questions that you think work, and you really evaluate at the point where they heard the question, did they comprehend it all the same? That's really, really important. If I ask you, does your 17-year-old daughter have any difficulty hearing? My first thought is, oh, heck yeah, she never listens to me. So that's a comprehension problem. I did not understand what you meant. But then I have to retrieve, okay, you know, I heard the question, and I think I know what it means. Let me retrieve an appropriate answer for you. Let me make a judgment about, is that what you want? Do I really want to report this? And then give you a response. The cognitive testing will take respondents through all of these processes, and that's what's going to happen as we move forward in developing these questions. And as you can see, at every point, there are external factors that will make a difference for that particular respondent. And the goal is to find a question where those influences don't matter. So this is my last slide. I know I'm trying to say a lot in a little bit. ACL has absolutely partnered with NCHS. They've been very gracious to us. And there are questions. Here's what we're doing right now. We are identifying questions to be tested. Some exist, some are brand new. We also have to identify questions to put in the screener. So this is a from scratch activity. We have to develop consent forms. Think about that. We have to develop a consent form for the IDD population. There's a lot of care kind of being put into this. Study design is being hammered out. There are going to be about 40 respondents this first round. We have to work out recruitment strategies, including contacting with service providers, advertisements, word of mouth. How do we find the people and make sure that they are representative of who we want? The IRB review at the National Center for Health Statistics has gone beautifully. This is a data collection effort. It is conducted by the federal government. OMB has to review it. OMB was furloughed. We are in a backlog. So the target date is summer 2019. We're keeping all of our appendages crossed that will continue to happen. And this time next year, Jennifer can come back and tell you what a success it is. So, thank you.
Does it? Elsa?
So they have Elsa's slides.
Right.
Do you want me to go next? Sure.
Is that easier for you, Andrew?
Yeah. Sorry about that.
That's right.
All right. Good afternoon, everyone. So I'm here to present some preliminary data that we've looked at the CMS Office of Minority Health on the characteristics of Medicare fee-for-service beneficiaries with intellectual and developmental disability. So just to quickly, is it the green? Okay, there you go. So just quickly, the CMS Office of Minority Health is one of 8 offices of minority health within HHS. Here we have our mission and our vision statement. So we strive to work with local and federal partners to reduce health disparities and improve the quality of health of all minority populations, including racial and ethnic minorities, sexual and gender minorities, rural populations, and people with disabilities. And here we have our pathway to equity. It has 3 interconnected domains. The first step is to increase the understanding and awareness of disparities. The second step is to develop and share solutions, and then implement sustainable actions. So now that we've gotten that out of the way, so this data that I'll be presenting today, we're working with ACL, specifically Andrew Morris and Amanda Reichard. So we're working on a paper presenting the preliminary results from this data. So today I'll present the prevalence of beneficiaries with IDD-related conditions, demographics, and health characteristics of this population. The data source for this work is the CMS Chronic Conditions Data Warehouse. There are a number of files in there, one of them being the Master Beneficiary Summary file and so on. It's calendar year 2016 data. Only Medicare fee-for-service beneficiaries with both Parts A and B benefits for the full year were included, and any Medicare Advantage beneficiaries were excluded from this work. So the 5 categories or IDD-related conditions that were included are autism, cerebral palsy, intellectual disabilities and related conditions, learning disabilities, and other developmental delays. These conditions, we use the ICD-9 and ICD-10 codes to determine these conditions. So for the study population, so there are about 60 million total Medicare population. Once you exclude the Medicare Advantage, that leaves us with about 67%. And then of those, the final sample size was about 31 million because we only included those who had Parts A and B benefits for the full year. Of the close to 31 million, about 75% are eligible to Medicare because of due to age, greater than or equal to 65 years of age, and about 25% have a disability or a disability with end-stage renal disease, and about 0.35% have end-stage renal disease only. So with that sample size, final sample size of 31 million, there were about 483,000 with one of the 5 IDD-related conditions that are listed here. So that's about 1.56%. And you can see the distribution of the conditions here. So within those that had IDD-related conditions, the 483,000, the largest diagnosis group was intellectual disabilities and related conditions, 70%, followed by cerebral palsy at 22.6%, autism 14.4%, learning disabilities at 10.7%, and other developmental delays at 8.5%. That's not on there, but. And so this slide shows within those who have any of the IDD-related conditions, the number and percent of those with one or more of the 5 conditions that are mentioned. And about 3 out of 4 of the beneficiaries have only one of the conditions. About 18% have at least 2 of these conditions, and so on. So this figure shows the age distribution for each of the specific IDD conditions. Total down here means if a beneficiary has any one of these 5 IDD-related conditions. And then as a comparison, I have beneficiaries with no disabilities. So you'll see here that for autism, over 90% were less than the age of 65. But then if you look at learning disabilities, 50.6% were less than the age of 65. For the other 3 conditions, they're pretty similar. About 3 out of 4 of the beneficiaries were less than the age of 65. And then if you look at the comparison group, beneficiaries with no disabilities, about 0.3% are less than the age of 65. So this is just looking at only the beneficiaries with IDD-related conditions, the age distribution. About 10.3% are less than the age of 30, and about 33%, I guess, are between the ages of 50 to 64. This next slide shows the distribution of the beneficiaries by sex. Although most of the conditions show very similar patterns where there are slightly more males than females, you can see that for autism, close to 3 out of 4 beneficiaries are male. Beneficiaries with learning disabilities are equally split. And then if you look at beneficiaries with no disabilities, there are slightly more females than male. So this slide shows the distribution by race ethnicity. I did not include each of the conditions because I thought it would be too cumbersome. But you can see here that for the beneficiaries with IDD-related conditions, about 3 out of 4 beneficiaries are non-Hispanic white, followed by African Americans at 14%, Hispanic 6.6%, Asian and Pacific Islander at 1.4%, and American Indian and Alaska Native at 0.8%. And you can look at the beneficiaries with no disabilities comparison, and you'll see, especially for African Americans, Hispanics, and AIAN, the percents are much less in comparison. And here we have the distribution by dual status. By dual status, we mean if a beneficiary has both Medicare and Medicaid. And in this case, full dual status means a beneficiary has both for the full 12 months of the year. Partial means between 1 to 11 months of the year. And no dual status means the beneficiary is not eligible for Medicaid. So here you'll see for each of these conditions, the patterns are very similar. And just as a comparison, if you look at the beneficiaries with IDD-related conditions, those who have full dual status are at 78.4% compared to 4.7% of beneficiaries with no disabilities. This next slide shows the figure by geography. So I don't have the other conditions just because it's very similar, the pattern is very similar. We're using the US OMB definition, where metropolitan is defined as a core urban area with a population of 50,000 or more. Micropolitan is a core urban area between 10,000 to 50,000. And non-CBSA is defined as less than 10,000. So here, even between those who have IDD-related conditions and beneficiaries with no disabilities, you'll see the pattern is very similar. So close to 1 out of 10 live in a non-CBSA or rural area. This slide shows just looking at certain chronic conditions, and here we have chronic kidney disease, COPD, congestive heart failure, diabetes, hypertension, and obesity. And you'll see that hypertension is pretty high in both groups, higher for the beneficiaries with no disabilities. But if you look at the beneficiaries with IDD-related conditions, the highest would be hypertension, followed by diabetes, and then CKD. And you'll see that for the other chronic conditions, it's much higher in the IDD-related group than the beneficiaries with no disabilities. And then this final slide shows just a breakdown of mental health conditions within the beneficiaries with IDD-related conditions. And you'll see that the highest prevalence is anxiety at about 31%, major depressive affective disorder at 28.9%, and then schizophrenia and other psychotic disorders at 20.4%. So just to quickly summarize what we've seen here, so a high percentage of Medicare fee-for-service beneficiaries with IDD-related conditions are less than the age of 65, are male, non-Hispanic white, have full dual status, live in metropolitan areas, have high rates of hypertension, followed by diabetes and chronic kidney disease, and have high rates of anxiety and major affective disorder. And just in terms of future work, so we're working with a number of clinicians and experts in the field to really look at each of these conditions and determine the accuracy of the ICD-9 and 10 codes and create larger categories of these conditions. So for example, for IDD, or it could be mobility impairment, or what conditions should go in, or what ICD-9, 10 codes should be used within each of these categories. And then after we do that, then it's easy to look at utilization, such as ED visits or preventive service, use of preventive services and so on. And also to validate, of course, the data against some of the survey data. And the other piece of the work is we have a component within CMS that conducts the Medicare Current Beneficiary Survey. And we're working with ACL again, once the questions have been, it might take a while, but once they've been tested and so on, to include those questions in the MCBS so that we can better identify the IDD population. So once we do that, then we can look at things such as access to health care, usual source of care, barriers of care, and so on. So that's coming soon. And that's all I have. Thank you.
Green? Let's see who's next. Oh, that's me. How do I go back? Okay, it is me. Hi, everyone. I'm Helen Lamont, and I'm here to talk to you about a new mode of data collection that we are exploring as we continue our work on collecting data on disability. So I'm from a little bit different office than ACL and CMS and OMH. I'm from the Office of the Assistant Secretary for Planning and Evaluation, or ASPE. So we're like a policy research shop in the Office of the Secretary, and we're charged with keeping a pulse of what's happening in the world, knowing data that we can refer to, doing research projects that are related to policy, and kind of having policy answers ready to go or to know who to go to when we get questions. So when it comes to collecting data on disability, as we've said all day, researchers and policymakers need timely, valid, and reliable data. We need both the holistic functioning measures and measures of population health, surveillance, but we also, and for us specifically, we need program eligibility measures, and we need to know if we're going to make a policy change, what population would be included, what population would be excluded. So the example that we always use is the CLASS Act, which would have been a long-term care insurance benefit that was in the ACA, and for that it had a very specific trigger level, which was the HIPAA definition of disability, needing help with 2 or more ADLs. And so we needed data on that, people who had that level of impairment in the working age population, so we could model whether or not this program would work and what different policies would impact on that population, on their spending, et cetera. And so we need data from traditional surveys, but the data that's available, especially on these ADLs, is becoming less frequent. And we also need information on, of course, how people with disabilities interact with the healthcare system, et cetera. So, as you know, traditional surveys are resource intensive, both in terms of time and money, and they've had declining response rates. So we're looking a little bit more now at internet panel surveys, which offer us an opportunity to collect data more efficiently and less expensively. So what is an internet panel? You've probably been gotten an email from somebody, YouGov, or one of these other places, and they've said, oh, enroll in our panel. And certainly the people who choose to respond to those might be different. But there are other panels that do a more rigorous methodological design that's more similar to our traditional surveys, and that was the group of internet panels that we were going towards. So an internet panel broadly is a sample frame of individuals who are recruited, either through that email you get or through probability methods, and they agree to participate in this panel. They provide some basic information, and it runs the gamut from age and political affiliation to a whole roster of information on your socio-demographic characteristics, your healthcare, health conditions, et cetera. And they agree to respond to surveys that are sent to them electronically. And the number of surveys you get a month varies. Often there's financial incentives or coupons that you get for participating. These methods are fast. They have high response rates. They're less expensive. You can field multiple surveys on the same frame. You can do a deep dive, so you can pull a group of people who have said yes to a question and do a focus group, and we've done that before. And the surveys are shorter because that whole set of socio-demographic characteristics or other health conditions and health characteristics that were in that core survey are already available. So you don't have to spend time collecting that information. But before we moved forward with collecting data on disability using these internet panels, we wanted to take a step back and look at them and figure out whether or not this was an approach we were comfortable going forward with and be a little bit critical of their methodology. So we had 2 research questions in a project that we did last year. Can we get valid and reliable national estimates on disability and informal caregiving? I'm going to focus on disability here, but we did look at the informal care question. And then if we can get that data, is it comparable to the rates of disability using traditional data sources? So we thought this would be pretty straightforward. We looked specifically at these 5 panels. GFK and NORC are the 2 probability panels, so those are the ones that we were most interested in exploring, although some of the other ones are really good. If you know that you want to ask a question of people with disability, they can recruit folks with disabilities, and you can have very targeted questions, and they have lots of people, and they're relatively inexpensive. But GFK and NORC usually use a household-based frame. They go to these folks, they send them a letter, they go to their door, they call them, they try to recruit the household into their panel. They have pretty high coverage. GFK has some access provisions, and NORC has a supplemental telephone survey mode, so you can use either the internet or the telephone mode. NORC's panel is relatively new, but it's being made by the people who developed the GFK panel, and so it's the smallest right now, but they're working on recruiting. So then we had to choose what surveys to compare them to. I'll go very quickly and just say we chose the ACS and the BRFIS and MEPS and HRS, and we looked at demographics and health items. We looked at subdomains, and then we looked at both coverage in terms of the total frame and non-response. So I'm hiding the 2 panels that we were most interested in with panel 1 and panel 2. But here you can see that when we went to analyze the data and we used comparable measures of walking or climbing the stairs and dressing or bathing, we found some pretty significant differences between the panel results and some of our traditional surveys. And then here's panel 2. Where the results are also different. But the other thing you will notice, if I had a pointer, was that there's a lot of difference in these measures on the traditional surveys. And so that sent us back to the thinking, to the thinking point. What's our next step? What can we do now? We have found that there is variation in methods. The panels were inconsistent. We think the inconsistency is due to coverage error, but we need to do some more analyses. And then we weren't that comfortable with the rates of disability using the internet panels compared to the traditional sources, in part because the traditional sources had such great variations. So we were like, all right, well, what's the next step? We don't feel comfortable moving forward just yet. What do we do next? So the next step is to go to the experts. So we're convening a technical expert panel, actually next Friday, to tell us what are the issues with collecting this data through an internet panel. And then if these are the issues, what do you need to know about how the panels do this in order to feel comfortable with using this methodology or this mode. Are there additional analyses that need to happen? Do we need to have more specificity? Do we need to know how they choose to have to code somebody or a household as not eligible? For example, if they have multiple people with dementia in the household, what do we need to know, and how can we move forward? How can we collect that data? So we're very optimistic. We hope that they have some really good recommendations for us. We assume there'll be some additional analyses that they suggest. They may just say you need to pilot test this. And the internet panels are very open to working with us to do additional analyses, to do data collection, and then they hinted that if they needed to supplement their methods in some way, shape, or form to provide this data to us, that they would be open to that. I will add that one important thing that we have to work through are the proxy issues, which Julie mentioned, because we're looking at disability 18 plus, and a big part of our interest is in older adults and people with dementia. What are the proxy issues, and how can you get good data on a population of people who may not be able to respond for themselves? And then we have plans done, but may not move forward with them, to design a survey instrument, which could go very quickly, it might not, and then it will be facing many of the issues that Julie has alluded to. But we would also like to piggyback off of the findings of their cognitive testing. And that was very quick, but if you have questions, here's my email. Thanks. Could be you. Thanks, I was like rushing.
Good afternoon. I realize it's late, so I'm going to go pretty fast. So I don't want you to have to be, if you took public transportation. But my name is Violet Wu. I'm at the Office of Minority Health. My colleague, Diane Wyszynski, she is the Office of Minority Health expert on data analysis, especially with IDD, and she regrets not being here. So I'm speaking on her behalf. Quickly, I'm going to go over the value of measuring race and ethnicity with this population. I'm going to briefly review the Federal and Department of Health and Human Services data collection guidelines, provide some examples of best practices to get more accurate data representing the race and ethnicity of the population, the data standards, and then the questions and answers at the end. At the beginning of this, Dr. Beatty, in his opening remarks, he gave you the equation for disparity as individual times environment. So the race and ethnicity is focused on the individual, so that's what we're going to look at today. One of the national standards that everyone has heard of is the Healthy People 2020, where we're looking at national prevention and wellness for the overall population. One of the focuses of it, and has been, is health disparities, which the Healthy People 2020 defines as a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. So race and ethnicity is not in the definition of disparities, but it is a demographic which affects the health disparities. In the Healthy People 2020, there's over 1,000 objectives. Each of those objectives has 9 required criteria. One of the criteria for determining the objectives is population disparities, and the demographics that are used to determine if that objective is valid is gender, race, ethnicity, sexual identity and orientation, disability status or special health and healthcare needs, as well as geographic location. So 2 items, race and ethnicity, as well as the disability status, are part of the disparities focus of Healthy People. As I mentioned, there are federal standards that apply to all the federal agencies, so not only Department of Health and Human Services, but such as Department of Commerce and Department of Housing, Housing and Urban Living. I can't remember what that stands for. But the OMB stands for Maintaining, Collecting, and Presenting Federal Data on Race and Ethnicity, was released in 1997. As mentioned, this is used by all the federal agencies to collect and report on race and ethnicity. And these guidelines are collected in all the national census that are funded and supported by the federal agency, ACS, NHIS being 2 of the ones that have been mentioned and that are used. So therefore, they are to collect race and ethnicity of the population that they are examining. To quickly hit on some of the best practices to collect or to identify the race and race and ethnicity of the populations is self-identification. That's a preferred method. An exception to this, in which it's not the observer or the surveyor who is categorizing the race and ethnicity of the person, is when observation identification is more practical. And a situation in which that is more practical is when you're completing a death certificate, so there's no next of kin available to identify the race and ethnicity. Also, for best identification, separate questions for race and ethnicity should be used when feasible. So the first question when the surveyor or the survey is asked, are you Hispanic and Latino or not Hispanic and Latino? And the second question identifies the race of that individual. The Office of the OMB Standards, which is released, it has the minimum set of categories for race and ethnicity. As you've seen in the past, for race, it's American Indian or Alaskan Native, Asian, Black or African American, Native Hawaiian or other Pacific Islander, and white. For ethnicity, you have two minimum set of categories. One, as I mentioned, is Hispanic or Latino, and the second one is not Hispanic or Latino. And I should have reversed the order of those to be in sequence. So when you're taking a survey or when you're asked a response, they do not have a choice of multiracial category, but the person can check more than one race if deemed necessary. Oops, I think I went the wrong way. Okay, and as many of the presenters have mentioned in the past, sample size is critical. That's why we have these 5 general categories for race and 2 for ethnicity, because you need an adequate sample size to be reliable, valid, and continuous. So additional granularity is encouraged if it's supported by the sample size, and the additional data that is collected can be aggregated into the one of those 5 minimum race and ethnicity standards. To give an example of that, for ethnicity, Hispanic and Latino or not Hispanic Latino, the general question is, are you Hispanic, Latino, or Latina, or Spanish origin? These are the 5 choices that you can respond to, that are the categories that the surveyor can respond to. But again, all of those can be aggregated into those 2 minimum requirements for ethnicity, Hispanic or Latino, or not Hispanic and Latino. Again, as displayed earlier, the OMB standard has these 5 minimum categories for race. What is your race? 1 or more categories may be selected. If your population has more, you want more granularity in the subpopulations, that can be done. For Asian, they have the choices of Asian Indian, Chinese, Filipino, Japanese, Korean, Vietnamese, or other Asian. And for Native Hawaiian or other Pacific Islander, Native Hawaiian, Guamanian, Chamorro, Samoan, or other PI are the other choice subpopulations. But again, those subpopulations can be aggregated into that overall minimum category. One thing I wanted to mention is that I was delighted to hear one of the panelists, I think it was on the first panel this morning, who was looking at intersectionality informatics with among the 50 states on disability. And so by that example she gave, they're looking at the Hispanic or not Hispanic for that data on disability, and I think that's planned to be released. She didn't say when it will be released, but that is what they're working on. So it is possible. A lot the national surveys, the federal national surveys and vehicles and tools are required to collect those 5 minimum standards for race and those 2 for ethnicity. These are the 2 links that provides the guidance for the minimum race and ethnicity data. They're on the ASPE website, but that provides more detail, and it goes beyond race and ethnicity. But the race and ethnicity are the ones that we are looking at right now, especially in the Office of Minority Health, and with a focus on disparities. If you have any questions, this is the contact information for Diane Wyszynski. Her email is there, and my email, and they added my number's there. So if you have any questions regarding that, please contact Diane or I, and we'd be more than happy to respond to your questions. Thank you.
Hello. So I am going to preserve 10 minutes for Q&A for the audience who has stuck with us till this very last panel presentation of the day before we have closing remarks. That said, I have 5 minutes to share some slides with you. Thank you to my funders at NIDLR and CDC. Thank you to the state of New Hampshire for providing insurance data, and this presentation is the responsibility of myself. As Katie Okoro mentioned earlier, there is a 10-state collaboration funded by the CDC that is currently using Medicaid claims to the Medicaid claims of people with IDD to study the prevalence, healthcare utilization, and effectiveness of care related to several chronic conditions, including, right now we're focused on diabetes, hypertension and heart disease, and epilepsy. We're just starting. And we are also working on a paper, collaborating among all of us, on avoidable emergency department visits. That work among the 10 states uses a common definition of IDD that starts with the CMS algorithm for intellectual and related disabilities, and then after soliciting input from the field, expanded to include also cerebral palsy and autism and PDD. So right now, the current algorithm that we're all using, and even within the 10 of us, there are slight variations, so that won't come as a surprise to some of my co-panelists, but it's close enough, we hope, that there are the ability to draw conclusions across states. In New Hampshire, specifically, because we are one of the states with access to all payer claims, we are working to bring in commercial or private claimants to add to the sample. And so far, our work is showing that this is important for various reasons. Of course, if one of your primary goals is to look at ways to reduce the cost of the Medicaid program, then drawing in commercial claims might not be at the top of your list. But if it is to understand the health and healthcare utilization of people with IDD, or for health surveillance, then we are seeing that it does matter. For example, even though the prevalence, unsurprisingly, of IDD among commercial claimants is much lower, in New Hampshire, we increased the sample size by 80% by adding commercial claimants. And I should point out that the way that these two samples are derived, we have Medicaid only, and then any commercial. So some of the commercial claimants here do also have Medicaid, but that's how we chose to break it down. We see differences in the prevalence and type of IDD between the Medicaid and commercial claimants. For example, compared to the Medicaid claimants, commercial claimants are less likely to have cerebral palsy, but more likely to have Down syndrome or autism, and less likely to have non-specific IDD. We also see differences in outcomes, okay? So among ED visits with hospital admission among children ages 0 to 17, I have a slide with the top 5 most frequent conditions that resulted. And some differences that we see are epilepsy is a lot more prevalent among the commercial claimants. And the top 5th cause is completely different. So non-specific findings on a radiologic exam versus symptoms of abdomen and pelvis. And it's similar for adults ages 18 to 64. Pneumonia is more prevalent among Medicaid claimants, whereas other lung diseases among commercial claimants. And again, the top 5th cause of ED visits resulting in hospitalization are completely different. Other procedures and aftercare in Medicaid versus septicemia in commercial claimants. This is a really brief, quick snapshot that I hope is piquing your interest. And what I can say is that our first publication comparing these two groups, it's myself, Andrew Houghtonville, and Amanda Riekert, and it became available online, the advanced online copy in the Journal of Intellectual Disability Research. So I'm not sure when it's in print, but you can look for that if you'd like to know more, or of course contact us. I want to say that the next steps in New Hampshire, we will continue to use our CDC funding to collaborate with the 10 states. We will continue to find ways to incorporate commercial claims and bring in and compare those differences in the expanded sample. And with our NIDLR funds under the new Stats RRTC, we are just beginning to conduct similar investigations with people with physical disabilities. So we'll have this as a comparison group as well as just as a new group. And we're taking similar steps to start with the CMS chronic conditions warehouse algorithms and then get input from the field to help determine which diagnoses and conditions to use to identify physical disabilities. Thank you. And now we'll go to questions.
One of the things I noticed is that a couple of you presented which groups you include in the group of people with IDD, and some of you included learning disabilities and some of you didn't. Some of you specified Down syndrome and some didn't. Some included epilepsy and some didn't. And I'm wondering if any of you want to comment on the impact of those choices on the outcome of your investigation.
I guess so when I was looking at the conditions, I mean, I deferred to the experts in the field really to help us identify what should be included or not. Specifically for Down syndrome, with the ICD-9-10 codes, it's included within intellectual disabilities. We talked about epilepsy, but these are things I guess we'd have to hash out and see what goes in, you know.
Hi, thanks for all your presentations. A couple questions. One was, why is cerebral palsy in the IDD but not spina bifida? Being that with spina bifida the shunt, and there's some other things that go on. And the other one was from another presenter with gathering data. There's a Washington group that has a whole system. I just don't know if you are aware of that or have used it and it doesn't really work.
I'm more than happy to talk about the Washington group. I will mention I'm a member of the Washington group. We've been working for about 10 years, and I believe the presentations from these compendium events are available online, and about 2 years ago, the whole presentation was about the Washington group questions. So now.
I just wondered if you said you're having trouble with doing a lot of identification because of people not understanding or, not having a consistent standard of what you ask and things, and I just knew about the Washington group questions and wondered if it was something that you knew about, but you do, so.
Yes, yes, those questions have been cognitively tested in the U.S. and internationally. We know they work. The problem with the IDD is the Washington group questions don't identify people with IDD. So when we add the necessary questions covering other domains, we need to know whether they work. And those are the ones that we will cognitively test. Any cognitive test should also include other operating questions to be able to benchmark, and the Washington Group 6 questions will be on this cognitive test. But clearly I was not clear, but I hope that helps, and I'm happy to chat with you further.
On to the other part of your question about why CP but not spina bifida. The short answer is I don't know. I was not part of the original 5-state group that decided on the enhanced algorithm, but I can find out, and by asking some of the partners who have been in since those days. I don't know if you know it. Okay, so I will get back to you. It's a good question. Thanks.
Add to that in regards to the work that Elsa described. Again, there was discussion about what groups to include and not include, and I think, the work that Elsa described is preliminary, and I think there's opportunities to further look at that data and what's being included and not included. But that was sort of a first step, and there was discussion about Spina Bifida and whether that would meet the criteria that we utilize for the DD definition.
Hi, so you all represent different organizations. So I'm interested in the way you go about formulating the questions and what is making you ask this in the first place? How are you collecting the data in the first place? Is it like an enabling statute or a regulation or a grant? Or, how are you arriving at it, your various organizations, at asking the particular questions and surveying the specific prevalence types?
Yeah, so for the Administration for Community Living, and I'm with the Administration on Intellectual and Developmental Disabilities, what really is prompting us to do this work is the statute that authorizes the programs that we oversee, and that is the Developmental Disabilities Assistance and Bill of Rights Act. And that legislation, or that statute, does define developmental disabilities, so that is the one that I'm referring to. That is, again, guiding our work, and we outlined, I think in various ways, the lack of good data that we have in this population. So we really, and we all know that there's a lot of public and private investments in this population to support them across the lifespan. And so to be better able to serve them, we want to know more about this population and better predict what their needs are, and then be able to design the programs that would really best support them and for us, it's living in the community and being included in the community. So that's really what's driving us. And I don't know if others want to speak to their drivers? Or.
Well, mostly for us, it's that NCHS has the responsibility to report, identify in the population, subpopulations and report on their health, and that's a big driver of the interest in this particular population. It is not our responsibility necessarily to report on the prevalence, the overall prevalence of subpopulations. So you definitely want to go to the census or the ACS if you want the official prevalence of fill in a subpopulation, and that's why I showed that slide with the decentralized statistical system. If you want to know the health of that subpopulation, then you come to NCHS. Here's the catch. That population is way too small to put questions on the ACS and derive an estimate that's going to be stable. And because you're going to want all of those other data points around just identifying them, but what is their utilization like? What is, all of these other things, then the health interview survey is one of the logical choices. There are others, but it's one of them. So we don't have to do this development work, but we have a really fabulous questionnaire evaluation and design lab. And that's where ACL is putting their resources to do that.
If I might just add one other thing, I think the collaboration and coordination across the different federal partners is helping us to think about other questions that we could be asking and other information that we could be looking at. So we're all informing each other because of the work that our agency is focusing on and meeting those information needs based on that focus. So for CMS Office of Minority Health, it's helping them to look more specifically within this population as it relates to minority health. And with this ASPE, it's an interest around policy and informing HHS policy as it relates to this population. So there's just a lot of exchange and dialogue that goes on between these different federal partners that is generating new questions and new investigations for us all.
this is just to piggyback on what she was asking about. So this is, I apologize for my ignorance up front about, but the condition of cerebral palsy, is that always contain a cognitive piece, a cognitive impairment? And if no, then IDD is more than just intellectual, there's another component to it. And I guess the secondary question would be, do you separate that out, and why are those combined? You know, because I thought that there was, you know, a delineation, and I'm not sure why they were combined. I guess that's another question.
So for our work, we have, we're approaching it we're identifying the population of individuals with intellectual disabilities, and then separately from that, identifying the population of individuals with developmental disabilities for the very reason that you just identified, that cerebral palsy may or may not come with intellectual disabilities. So we want to be able to understand the two populations and their prevalence, but also their health status. And we have utilized definitions for each population, taking the functional approach as described by Julius, why we would want to do that, so that, again, we can work to identify those two different populations separate from one another, because, again, they don't always co-occur, and intellectual disabilities can be a separate type of disability or condition that a person with a developmental disability doesn't always experience.
Same with us, same with us. We do combine them in the same research project, in the same papers, but we don't lump them together in one group like a yes or no, or separated out by developmental or intellectual. So I don't know if that's a satisfactory. Do we have time for one more?
I know one of you mentioned proxy response, and I wanted to come back to that a little bit, both in terms of, Julie, the cognitive testing now that you're planning to do. Where are you at in terms of testing the questions with proxies, given that about 70% of the people, when the NHIS was began to allow proxies, 70% of the people with IDD had a proxy respondents who were adults, and then also the internet panel survey and proxy, and how you're thinking about that.
So just to give everybody a real broad feeling for this, the proxy response rate in the National Health Interview Survey is pretty small. It's less than 2%. People who really worry about how proxy responses, bias the data, we generally, assure them that they don't have too much to worry about. So when you hear, the statistic about people with IDD generally, like in the HISD in 94, 95, had almost 70% proxy rate. You know that this is a population that no matter when you try to identify them, you're going to have to deal with this issue. So during the testing, both individuals and proxies will be included. And at times, in fact, most of the times, individuals and a proxy will be asked the questions, because you can't determine, you can't make a comparison if you don't do both. So that's how we're going to handle that.
Everything that Julie said, but then we're also going to look at, we've heard anecdotally from people who are out in the field recruiting people, that if they go to a home and there are two people with dementia, for example, or people with IDD, and they don't feel like there's a proxy there, that they will code that home as not eligible. And so we're going to even back it up a little bit more from that and think about making sure that if you're sampling at the household level, that you're still recruiting households that have people with disabilities, even if they need a proxy to respond for them. And if that's a population that we can get to here, because we are concerned that there might be some bias in even who's included and not measured in non-response because they're not eligible.
Thank you so much to our panelists and our audience for the great questions. I'm going to